Hello, and welcome everyone today to today's webinar on new ways of working using virtual wards and thinking about how virtual wards is evolving and shaping our practice. We're really delighted to have you join us today, and I'm really thrilled that we've got some great experienced speakers who've got a wealth of experience in developing, designing, implementing, running virtual wards. I have been fortunate enough to have the pleasure of visiting a number of virtual wards in my previous role as CNIO for England. And there I saw the positive impact that these services have on both patients and staff. But I also heard of the challenges in delivering and scaling this mode of care delivery. The recent NHS Confederation report articulates these very clearly, so is well worth a read. I've also had the pleasure of leading the Phillips Ives review, which examined how nurses is changing and will change in the next 5, 10 and 20 years as we embrace more and more technology and data to underpin our practice. And what we heard really clearly through that review was that person-centred care must be at the heart of our evolution. And what I've seen with virtual wards is a real focus on person-centred care and real opportunities to deliver that, which we'll hear about from our speakers today. And we also heard that digital technologies provide the opportunity to deliver this person-centred place-based care in new ways. But most importantly, what we heard loud and clearly from our profession and from others is that nurses must lead and shape this future. So if you take nothing from today's webinar, a key takeaway is that this is a call to action. So hopefully you will really reflect on what you've heard today and think about how you might take that forward in your roles as nurses. So we're going to kick off. We're hoping to have lots of discussion because clearly there are lots of opportunities and challenges, and it will be really great to get into some rich conversation. So we're going to kick off firstly with a poll to hear from you before we go on to our speakers, in the spirit of really getting you joined in and ready to contribute from the outset. So Jen, do you think you could put the poll up for us? And while you're doing that, I'll just call people's attention to the top right-hand side of their screen. They have got, on the third tab, it looks like a bar chart. If you click on that, that's where the poll will be, but it should also appear in the chat in front of you as a link. So what are your thoughts? What do you think is the biggest challenge facing the nursing profession in delivering virtual wards? Is it staff shortages? Is it equipping teams with the knowledge and skills to best deliver virtual wards? Is it a lack of buy-in from the professions as a whole? Or is it patient distrust of digital technology in health monitoring? You may think it's more than one of those, but if you could just plump for your key, most prominent challenge, that would be wonderful. Thank you very much. And it's interesting to start looking at these results as they start coming in. Thank you very much, everyone. Unsurprisingly, probably, staff shortage is the #1 challenge that we face. And we know all our professions have got real challenges with staffing, not helped by the sort of low morale and challenges we've had, post-pandemic, and the recovery phase leave us with quite an exhausted workforce. So a really interesting challenge that I hope we'll hear more about from our speakers shortly. But also what I'm quite interested in is the fact that actually the lowest scoring is that patient distrust. And that, I don't know about you, but that fits with my understanding that really patients are keen to have the opportunity to have access this sort of care where it's appropriate. And then a big #1 that we also heard about in Phillips Ives coming up close behind staff shortage is that knowledge and skills. So hopefully today we're going to address some of that by giving you some new knowledge that will help you to forge some new skills. So in order to get to that place, I'm going to start to hand over to Niall Keenan, who's a consultant cardiologist and the clinical lead for Virtual Hospital in the clinical advisory group of virtual wards in NHS England. and he's going to talk a bit about those findings that I mentioned in the NHS Confederation report and dive into the detail to explore how we ensure we tackle some of those workforce challenges that you have said that we have and that we have heard loud and clearly. So over to you, Niall.
So I've been asked to talk about virtual wards, new ways of nursing, setting, and to try and set the scene. So I'm Niall Keenan, I'm a cardiologist in Watford. I'm also the Clinical Advisory Group Chair for Virtual Wards in the East of England. I sit on the National Steering Group for Virtual Wards. Next slide, please. So Virtual Ward in Watford started in the COVID pandemic. My colleagues in the top of the middle of this picture here, Matthew Knight, Andy Barlow, set up, I think, the first virtual ward in the country for COVID and put 6,500 patients through that virtual ward during the pandemic. Post-COVID, then we were thinking, what pathways would work for us for virtual wards? And in end of 21, we launched our virtual ward for heart failure and COPD. And we've now put nearly 1,000 patients through that virtual ward, focusing primarily on a early supported discharge model, but with some community prevention of admission. And as you can see by this little photo montage, we've had quite a lot of interest in what we've been doing. We've had all sorts of VIP visits, media, TV, and I think it just shows the extreme level of interest in virtual wards at the moment. But I think the crowning moment, if we go to the next slide, was last Sunday when we had the privilege of, on a Sunday evening, hosting Prime Minister in our virtual ward hub. He'd heard a lot about virtual wards. I'd spoken to him about virtual wards in the past, and he wanted to come and see what we were doing. So that's our virtual ward hub there. That's two of our nurses. Leanne on the right is the lead for community services and CRCH, and that's the MP for Watford on the left. But if I can go on to the next slide, these are really the key people who actually make this all work. These are our nursing team in the virtual ward hub, and that's what I'm meant to be talking about today, new ways of nursing. And what does it mean for nurses working in the virtual ward environment? And what I would say is that my impression is this has been a phenomenal experience for our nurses. Their enthusiasm is absolutely palpable every day. We've got a team of, I think, a matron, 3 band 7s and 10 band 6s, plus admin support. So it is a big nursing team. Next slide, please. I put together a few thoughts on the next couple of slides about this question, new ways of nursing. So first, what is the role of a nurse in virtual hospital? It's very different to the role of a nurse in the ward or the role of a nurse in the community. And I'll just make a few key points. In the hub, a key element here is remote monitoring, as you can see in the picture. The patients have their remote monitoring devices at home. They're transmitting data to us in the hub. We are monitoring that and getting alerts on the system, seeing what's going on. Patients have to fill in a questionnaire every day, asking, have you got any chest pain? If they say yes, then we get an alert about that. So there's a huge amount of time spent monitoring patients. Then the next thing, patient contact and support. Obviously, these are patients who would otherwise be in hospital. We need to try and, as closely as possible, replicate the hospital experience by staying in close contact with the patients and giving them the support they require. Management, changing their treatments as required. Pharmacy is vitally important in virtual ward, and so the nurses have to liaise with the pharmacists about adjusting medication when they don't have the patient in front of them. And record keeping is obviously absolutely key as well, on a variety of different electronic record systems. So I think those are probably the key roles of the nurses in the hub. Who else is in the hub? It's a very mixed team: consultants, GPs, other nursing teams, for example, heart failure nurses or COPD nurses, pharmacists, admin. So it's quite a mixed team, and I would say a very flat structure. And then on the right-hand side here, other nursing roles in virtual hospital, because it's not just about the hub. Our nurses get out, they go onto the ward, looking for patients who would be suitable for virtual ward, spreading the word about virtual ward, educating people about virtual ward, onboarding patients who are suitable, training patients to be, when they onboard them, liaising with clinical teams about potential patients for virtual hospital. And then, of course, there is the nurses in the community, also a key part of the virtual hospital team, supporting the service, delivering, I suppose, what we sometimes call hospital at home, visiting patients in their home, doing blood tests, giving them furosemide, and doing point of care testing. That's POCT. And then, of course, it's very important that we liaise with other nursing. So we've got the hub nursing team, then we've got the heart failure nursing team, the COPD nursing team, the different bits of the community service with our partner CLCH. So it is a very different way of nursing. Next slide, please. And the staffing challenge is obviously very real. I think the first question is, where are these nurses coming from? Very often they're recruited internally. So then how do we fill the gaps that leads to? Training, I think we're going to be hearing about later on the webinar. What training is available? There's nothing absolutely set yet. We've done quite a lot of competency-based training inside the Virtual Hospital Hub, and I think Sarah Zaidi in Essex is leading something nationally to do with their training modules. So training is really important, and that's sort of in development. Nursing ratios, also a key question in nursing. I think it's really difficult to be prescriptive about that, because virtual hospital incorporates an enormous range from patients who are visited at home 2 to 3 times a day to people who might have a telephone call every other day. So you can't specify the nursing ratio until you're clear about what acuity we're talking about. And then a key thing here, working in a different way. This is really, I guess, my most key point. There's a lot more autonomy for nurses. There's a lot more, self-directed work. So that can be a challenge for some, and it's very inspiring for many. The structures, it's less structured than working on a ward in different structures, and that being able to work in a different way is really a key point. But I think we sometimes in virtual wards hear a lot about what the staff experience is, and the staff experience is extremely positive, I would say. I think our nurses are truly inspiring. And if you look on Twitter at VW West Hearts, that's the Twitter feed the nurses set up, and you don't need to look at it for long to see a lot of their enthusiasm. Next slide, please. Those are the key points I really wanted to say about the topic that we're meant to be addressing today. I just want to make a few more general points then. What virtual ward is and what it isn't, because I think there's often some confusion about this. Patients in virtual wards should be in a virtual ward as an alternative to being in an inpatient bed, and it is an intervention that it should be broadly speaking, time limited to 2 weeks. So it is not the equivalent of remote monitoring. It's not long-term treatment pathways. It's not the same as a virtual clinic. It's an alternative to bedded care with a 2-week intervention. Next slide, please. Virtual wards, I guess, come in 2 flavors. There's mostly remote monitoring, the sort of thing I've been talking about, and mostly face-to-face, what we call hospital at home or frailty. That is the sort of whole range of virtual wards. And then there is the, I guess, broadly speaking, early supported discharge model that we've done a lot of. There is the community prevention of admission model. And then there's sort of in between the two, turning patients around in ED, onboarding them in ED, which is probably the hardest because you need a lot of staff to be ready to go and see patients who are on the clock down in E&E and A&E and get them home. Next slide, please. This is thought of as really part of a spectrum of care where hospital at home is the most intensive, and on the left you see preventative care, long-term condition management, anticipatory care. So it's best thought of in this sort of, sometimes this is shown as a pyramid, at the top of a pyramid of managing patients in the community. Next slide. The national ambition is 40 to 50 virtual beds per 100,000 population. That is a lot of, we have in Watford a hospital of about 600 beds, and we're meant to be heading towards 200 virtual beds across our whole HCP. So when fully delivered, this will be a very significant proportion of the national bed base. There's already 10,000 virtual beds nationally, so we're halfway to the target. But I think if one looks at the staffing allocated to virtual wards versus the staffing allocated to inpatients, there's a major disparity. So sorting out the staffing to get virtual wards adequately staffed to reach the ambition is vitally important. Next slide. I just mentioned here some key pathways because I think Sometimes people think of virtual wards as just, COPD, heart failure and frailty, but they're being used for all sorts of things: palliative care, elective orthopedics, elective surgery, children and young people's mental health. There's a huge range of possibilities for virtual wards. Next slide. On this slide, I won't dwell on this, but these are just some key principles that I've laid out. Next slide. This shows what some people are doing with this. So this is Mid and South Essex, and basically if you phone NHS 111 999 or community services there, they have what they call a virtual A&E, where they triage you to physical hospital or virtual hospital. That's how proactive they are being about getting patients in the community into virtual wards rather than bringing them to the physical hospital. It's it's a seriously impressive model. Next slide, please. I just wanted to touch on this. This really important report NHS Confederation brought out a month or two ago, called Realising the Potential of Virtual Wards. This document is primarily looking at virtual wards in the round, but it focuses quite intensively on the staffing challenge, particularly to do with nursing issues. Next slide, please. This QR code takes you to the full report, and it's worth a read. It's about 20 pages long. It's a good read. Next slide. I'm just going to show some excerpts from it. Virtual ward staffing needs to be properly planned. This is a key point. Sometimes that systems are asked to sort of roll out a virtual ward, and people say they're going to set one up, but they've not sat down and carefully worked out the additional staffing, because this is staff intensive. I think our virtual ward at the moment in Watford or West Herts has, I think, 35 whole-time equivalent staff working on it. So proper staffing is very important. Next slide. It says in the report, the government and NHS England should approach virtual ward expansion as a coherent, larger scale and holistic digital project. I mean, I totally agree with that. There's a huge amount of connectivity issues that the virtual wards raised. And as I said, it interlinks with a broader piece of work on remote patient monitoring in the community, not meeting that 2-week target. So there's some very nice work from Imperial, for example, showing that remote monitoring in heart failure reduces admissions. So, and other projects like that. So it's a part of a larger piece of work on digital. And then this important comment at the bottom: workforce and skills shortage in the NHS is impacting on systems' ability to fully develop, deliver, and scale the full ambition of virtual wards. And that's what we're talking about: training staff to be able to work on these pathways and having enough nurses to do them. Next slide, please. So really, nationally, I would say this has been a spectacular initiative. 100,000 patients have been put through this in a very short period of time, and it is very impressive. When done well, it really makes a difference. It makes a huge difference to patients. They get to go home. There's a much better patient experience. Very safe. Our own data show that people go home about a third earlier. Patient feedback 9 out of 10, and no signal for safety. So it is an excellent. It's an excellent project. The challenges I've listed: staffing, funding was ring-fenced and now is part of the UEC budget, so people working in the virtual ward space need to make the case and show the impact. We have to be willing to change existing clinical models. That's particularly directed to many doctors who are much more comfortable looking after patients in hospital than in the community. The willingness to do things differently, that's both doctors and nurses. As I've said, the way of working in the hub is very different from on a ward. And engagement of a fatigued workforce is really important. Next slide. But this quote's often given to Einstein. I don't know if it is Einstein or someone else, but anyway, it says, the definition of insanity is doing the same thing over and over again, expecting different results. We know that there's a serious pressures in emergency departments, and we can't solve that just by bolting on more and more surge capacity. We need to look differently at what we're doing, why we have patients in hospital, who doesn't need to be in hospital, where the right place for that patient is, in order to drive things forward and make a difference. And virtual wards is a really key part of that. Next slide. So thank you very much for your attention. Thanks to my colleagues who I've listed here, and thank you to our wonderful nursing team, and enjoy the rest of the webinar.
Thanks, Natasha and Niall, for the introduction. So my name is Jen Tomkinson. I'm Head of Specialist Services and I'm a clinical lead for NHS at Home, which is our virtual wards within Bristol, North Somerset and South Gloucestershire. And I'm going to be talking a bit about how setting up a team for success in virtual wards and the new ways of nursing and some of the things that we've considered. I'm going to talk a little bit about our journey so far and what's different about this model of care to usual care, some of our challenges, and then some of the things that we've thought about to try and overcome them. And then a couple of quotes from some of the people in the team describing what it's like to work with us. Next slide, please. So a virtual ward manages people who should be in hospital and delivers acute care in the person's home. It's a blended model of both direct and virtual clinical care, enhanced by technology. Patients can have a spectrum of interventions as part of the virtual ward, from 100% remote monitoring, such as COVID pulse oximetry monitoring, all the way through the spectrum to 100% face-to-face delivery, for example, a hospital at home model. All of our patients within BNSSG are offered remote monitoring through Doccla, who are our partner technology company. And that allows us to be able to offer both vital signs around the News 2 scoring, as well as symptom scoring. We set individual thresholds for the person, and these are monitored by clinicians at our hub. And there's a photo of me in our hub on the slide. The delivery of the care is done through a team of teams. And again, on the right-hand side of your slide, you can see our team of teams. And this is delivered through a collaboration between ourselves within Sirona, the community provider, as well as the two acute trusts, University Hospitals Bristol and Western Trust and North Bristol Trust. And that has been about bringing together those three teams of teams in order to deliver a collaborative model. We call it lanyard ambivalent, with the idea that any of us could be delivering the care for that person within the community and supporting them at home, but bringing together those skills from both sides of the community to be able to deliver that care. Next slide, please. Our journey has been ongoing for the last few years. COVID brought us together as we looked to deliver COVID pulse oximetry through a group of interested people who got together really by osmosis. At the height of COVID pandemic, we reached a capacity of 750 patients being managed on our COVID virtual ward. And then through 2021 and 2022, we started to collaborate on further pathways. We developed a system-wide OPAT service, which is an outpatient parenteral antimicrobial therapy service. And then the virtual ward guidance came out from NHS England, and we started to look at developing and enhancing existing pathways within the system, including respiratory, heart failure, frailty, and general. We procured the Doccla system in the middle of 2022 and rolled out our first pathways for both OPAT of 16 beds and respiratory of 15 beds in autumn 22. And then we further developed our capacity and pathways through 22-23 and now have capacity for 120 beds. Our next milestone is 165 beds by the end of this year. And the last technological element has been rolled out in this April-May time of full News 2 monitoring. Next slide, please. So what's clinically different about a technologically enabled virtual ward? This diagram shows a usual early supported discharge or alternative to admission pathway for a respiratory patient such as COPD. The patient would have been seen at home, those yellow arrows describe frequently during, say, a 14-day length of stay being visited at home. They would have had either visits or, as the pandemic came, we started to do more of those visits through virtual means, through telephone consultations, for example. And as you can see, the consultations start quite frequently at the beginning of the person's journey and then spread out as the person starts to improve. At the time, we had a once-a-week multidisciplinary team meeting with a consultant where we could discuss any issues, and that allowed us then to be able to escalate as appropriate. Next slide, please. So what's different about a virtual ward? The technology that we have being measured daily can be used up to 4 times a day. And that means that we have vital signs and symptom data, a much larger amount of this data than we've ever had before. Because the thresholds are set for the individual, it means that if everything is within normal limits, the patient won't escalate and we can just carry on with usual care. And for those that then escalate, we can then target and speak to them, perhaps find out more about that problem that they've got and do something about it. It also means that when we do visit the patient, we have more data, which allows us to be able to target our intervention to much more about what the person is interested in and what is a problem for them at the time. And what it's allowed us to do is reduce the number of specialist input visits that are required through that length of stay within our virtual ward. We also have daily multidisciplinary team meetings, or board rounds as we called them, with the consultant. And that allows us to be able to discuss more of the patients more frequently. And it means that we can offer more interventions to support acute care. So for example, we are now offering oxygen therapy in the acute phase rather than the chronic ongoing phase if required. And the Doccla team also support us with some of that work by both issuing the Doccla box and supporting the onboarding of the person to the technology. So using their expertise to actually help the person be able to use that technology effectively. Next slide, please. So I've just put this slide up here, and when you get the slides, you'll be able to see this, but there's really, really good evidence that virtual wards are delivering better outcomes than the equivalent treatments in acute settings. They're demonstrating less functional decline, an improvement in social care outcomes, less infections and lower readmissions than usual care settings. So they're safe and an effective way of managing somebody. Next slide, please. So developing our workforce to deliver the model has been a learning challenge for us. What some of the things that we've developed is that we try to develop a model with the patient and their carers at the centre of what we're trying to do. And then our remote monitoring hub and clinical delivery team who deliver that care, wrapping around that person, supported by specialist healthcare professionals, respiratory, frailty, heart failure, whatever the person's need, and also medicine specialists from our pharmacy team. There is then a higher level of people above that, which is our consultants and advanced practitioners supported by GPs, who are the point of escalation and enable us to be able to hold more risk and acuity in the community. What we've learned through our time developing this workforce model is that there are some challenges around the terminology of virtual wards. So for example, virtual wards don't mean 100% virtual ward working. And we have had some challenges in terms of recruiting people because they imagine that the roles may be 100% working from home and that they may not be required to go and visit someone in their own home, for example. And we've had to bust that myth in terms of actually there is a need to deliver care. Transferring confidence in our competence to be able to deliver this model has also been a challenge. As well as the complexity of integration. So when I said that we were trying to deliver this through a team of teams, that has added some complexity around things like standard operating procedures and policies being different between the three organisations, but also ways of working being different between the organisations, and bringing those together and aligning them has been a big piece of work that we've needed to do. The other thing about working as a team of teams is that our view of risk can be quite different depending on the space in which we're used to working in. So a difference in view between community staff who may be very used to visiting people in their own homes and the complexities and dynamics of that versus those that have worked in hospital and may see things quite differently. And this has also been a completely new model of care. So, sorry, do you mind just going back one slide? Sorry, thank you. This has been a new way of working. We didn't know how much face-to-face versus virtual we would need. And so designing our workforce and understanding what our safe staffing levels has required some iteration through time. But there are some really good things about this kind of model. Hybrid roles for staff has been one good one where we can allow flexible working to allow people to have some time working from home, for example, as well as still delivering face-to-face care which our healthcare professionals enjoy, and also building on the competencies that people have and use every day in their usual working life. We've been able to share those and show that it's very similar. Next slide, please. So how have we gone about it, and some of the things that we've thought about in terms of those challenges? Developing skills in virtual triage in order to support the assessment and personalised care planning for people has been very much linked to our staff determining clinical risk and acuity. And this is often for a cohort that we haven't seen. So building the idea of a trusted assessment from one healthcare professional to another. And this informs decisions about what model of care is delivered. So when to visit the person and deliver a face-to-face intervention, what can be done remotely, and ensuring that we then tailor the care to that individual person. It requires a shift of us as healthcare professionals from being experts to empowering patients and their carers. We need to train and support them in managing more of that self-care, but also trust that they will escalate. So if they become unwell out of hours, that they will phone and ask for help. As healthcare professionals, moving to more remote ways of working, we need to develop skills in both managing and describing that escalation process, both to the patients themselves, but also to our colleagues, building that trust between the community team and the hospital team. And the use of SBAR and teaching that, supporting the staff with that, has been really helpful to create a framework and shared understanding between different organisations and different healthcare professionals. And describing that risk between us and other healthcare professionals is a real key element to this model working. So using that same language is really, really important. But also, we have to support that cultural shift and supporting our staff to use more courage-based healthcare, to take the risk, to take the person out of hospital, and to trust that they will be managed effectively. Technology as an enabler to care is also an element of competency that we need to develop often within our teams. There is our staff being able to train patients to use the remote monitoring equipment, considering things like the digital literacy of the person, but other barriers that person might be coming across, such as language or having a learning disability. And using the technology as an enabler to be able to support the decision making that you're making, and trusting in that is something that we've had to work with our teams towards. And one of the things that one of the advanced practitioners said to me the other day, and her quote is in yellow there, is that I have more information, so I have much better clinical oversight and can hold more risk than I've ever done in the past. And she came from a urgent care response role into the virtual ward, so was already managing quite a lot of clinical risk in the community. But this, having the data, having the information, has really supported her decision making. But also there are skills around developing the ability to be able to assess somebody over the telephone or via a video call. So developing those remote assessment skills is a key for us. And then the last thing that we've had to think about is in terms of our leadership and behaviours, and in our aim to develop a collaborative model of delivery, working across the boundaries of our ICB. We are using that remote technology to be able to enhance some of the communication between us. So the use of Microsoft Teams for video calls, for example, the use of the Microsoft Chat. And that means that we also need to think about the etiquette of how we are doing that between teams and also within teams, and ensuring that either it doesn't become so overwhelming, the amount of information that's in those chats, that it's no longer useful to staff and creates clinical risk, and that it supports people to still feel like they're part of a team. And we know that video calling does lose something for us in terms of building a team of teams. And we know that building that team of teams is often linked to relationship building. And again, that then links to our trusted assessment model and building those relationships with acute colleagues and with GP colleagues in primary care in order for them to buy into that model. So part of this is about developing a culture, a different way of working between us. And those are skills that are difficult to train in, but are things that you need to consider as part of your development. So I've tried to talk a little bit about our journey in developing a virtual ward and our team of teams and our learning that we've taken from developing our workforce model, including some of the challenges that we've faced and some of the things that we've tried to overcome. I would just like to say thank you very much for listening, and I'm happy to take any questions.
There were two really important messages that I hope to pick up on in the questions with you after, which were that team of teams concept was really interesting to me. And that paradigm shift, which seems so fundamental in moving to this type of care. And there's some themes coming out in the questions from you guys out there. I can see a lot of questions about how we handle inclusion and making sure patients can have and access the kit they need to do this. A lot about staffing ratios and skill mix that we'll come back to. And that role of the nurse leader. What do you need a nurse lead role was something that came out. So we will come to your questions, but before we come to your questions, I want to introduce our third and final speaker, and that's Becky Ashworth. Becky is a trained nurse with a background in acute medicine and research, and she now leads Doccla's clinical engagement and clinical safety function. And she's going to talk about the opportunity virtual wards offer for teams. So over to you, Becky, and anyone else who's not speaking, could you please turn your microphones off? Thank you.
Hi, yeah, thank you so much for that introduction, and thank you for having me. So yes, my name is Becky. I am lead nurse for clinical engagement and clinical safety officer for the virtual ward provider called Doccla. And I'm going to spend a few minutes talking about what it's like being a remote patient monitoring nurse. And the really nice thing about the presentation that I'm doing today is I've done something very, very similar in the past. But it's been just purely from my point of view, whereas actually we're growing to a place now where we have a team of remote monitoring nurses. So it's been really nice to ask their input and have a few of my points validated, as well as some extra points for discussion as well. So please, could we move to the next slide? Thank you. So just to give you an idea of what Doccla do, and this is purely so you can sort of envisage where my experience is coming from. So Doccla provide an end-to-end service for virtual wards. So we take responsibility, for all of the monitoring devices and the logistics. So when a patient is referred onto our service, they are given a Doccla kit box, which contains all the health devices and a smartphone that has the app on the smartphone already installed. A team of customer service agents that belong with Doccla will then support the patient to use those devices and onboard them onto the app. The patient submits their readings via the app, and these appear onto the Doccla dashboard or the clinician web portal. Me, as the remote patient monitoring nurse, I will log on to the Doccla dashboard and I'll see their readings and action alerts appropriately. One of the barriers that we found to scaling virtual wards is that clients just didn't have the clinical capacity. So we are a CQC registered organisation and we can provide clinical support. And that's where my experience has come from when I've been monitoring on behalf or for our clients. Next slide, please. So as nurses, we like to know that we go into nursing because we like to care. We like to know that we are making a difference or having a positive impact on someone's life. And I could talk for a very long time about the benefits for patients being at home and on virtual wards. The direct benefits include patients reporting feeling like they've got more time with clinicians. They have less interruptions on their consultations and get to maintain their privacy. There's the obvious benefit of if a patient isn't in hospital, then they're not going to develop hospital-acquired infections. Indirect benefits include things like recovering in their own environment with their own nutrition and their sleep pattern and access to their loved ones. And I really want to highlight those points because although they might not be the first thought for virtual wards, but those points there will have a direct impact on the patient's immune system at a time when we need them to be recovering at their best. So I think it's really important to highlight those ones. Utilising the tech of virtual wards means that there's often an open line of communication. So patients can send messages and patients can send messages via the patient app. And then it just means that nurses are able to get back in touch with them at a time that's convenient for both parties. Potential benefits, for example, are it might be that older patients are more likely to move around in an environment that they're familiar and feel safe with, so they're less likely to develop pressure sores. It might be that elderly patients are less likely to develop delirium. And a really exciting point of virtual wards is that it's an opportunity to offer health education and offer some more intensive support for self-management of long-term conditions. It's not uncommon for patients to ask at the end of their time on the service, where can I get these devices? And that's really rewarding as a nurse to know that we've offered some health education there and they understand what those readings mean for them. And next slide, please. So what is this like on the nursing side? What are the benefits for being a remote patient monitoring nurse? And these are the points that have come from our team of nurses. So we find that we have more time to assess and to care for our patients. A lot of our nurses have come from a background in A&E, like myself, and so it's not uncommon when you're on the ward or in A&E to have someone pop their head around the corner of the curtain, and you won't have that if you're based at home, working at home, monitoring your patients. It just means that there's less interruptions and that patients can maintain their privacy. It also means because we're removed from the patient's home situation, it allows to offer a more patient-centred care. We have no choice but to utilise the resources that patients have at home, and this is individual to each patient. It also is an opportunity to really hone the assessment skills. I will hold up my hand and say that before I went into remote monitoring, given my background as A&E and research, there was a part of me that worried that perhaps remote monitoring wouldn't be challenging enough, and I was very, very wrong. In order to be a safe and effective remote monitoring nurse, the clinical assessment skills have to be really honed. You have to be really attuned to what the patient is saying and skilled at drawing out the information, just so that you can rule out the red flags and assess exactly like you would as face-to-face, but it's over the phone or via video consultation. The benefits for the nursing workforce are similar to other professions that work at home. It's a better work-life balance. I live in a studio, so my commute to work is 3 meters from my bed to my desk, which means I'm less fatigued, I have more energy to care for patients, it's likely better for the environment, we're not using our car as much, and one could argue that there will likely be less sick days as well. Next slide, please. Thank you. And I wanted to finish on this point. I think it's a really important point to highlight. So I got permission from one of the nurses that gave this comment to use it as verbatim. So they stated, working as a remote monitoring nurse has allowed me to continue my nursing career despite having a long-term health condition / disability, which I am so grateful for. It has allowed me to still use my nursing skills, but in a different setting. And I think this is a really good example of how we could reimagine the nursing workforce and how remote monitoring could help us retain more nurses, but also expand the nursing workforce. Remote monitoring offers continued career for nurses who sustain injury or burnout, or just no longer want to be part of no longer want to work in a physically demanding role. It's an opportunity to hone nursing competencies and develop new skills. And I've been in touch with academics where they have spoken to Doccla about developing a unique remote monitoring module that's for traditional nursing, but we could take that one step further. Traditional nursing is quite a physically demanding course to take, and by default, we therefore rule out a portion of society. Could it be that a new nursing discipline such as remote monitoring allows for people who are unable to take the traditional nursing route to start a career in nursing, thus increasing the accessibility to nursing workforce? Next slide, please. So thank you so much for your time, and there's my contact details. Please reach out if you have any questions, and I will be answering questions as well. Thank you very much.
Right, let me just, is my mic on? Yes. Thank you. That was a fascinating presentation, and thank you to all 3 speakers. You've done a sterling job. Despite the technical challenges, we are exactly on track in terms of time. So we have left 15 minutes for discussion, which is fantastic. And there's lots of comments and questions coming in the chat. And I am going to try and group them together so that we get through as much as possible. So one of the let's kick off with a question around this education and support that you talked really interestingly there, Becky, about the opportunity potentially for the future. That was something I hadn't thought of training for people who couldn't access nursing otherwise but could do a sterling job. So that's something, a takeaway for me to consider. But thinking about our current workforce and those advanced clinical assessment skills, what do you think a good program of education looks like, or what have you seen? What are the types of education you've seen providers put in place, and what do you think we should do as a profession, maybe building on that nationally?
Yeah, so I think as the remote monitoring nursing role becomes more common as virtual wards are scaling, we are having to think about what are the unique and specialist competencies that we need to consider, that we need to train nurses for, and this is something that we're focusing in-house in our own team of nurses. The nurses that we've recruited at the moment are highly trained in clinical assessment skills. They're used to working autonomously, and they're used to dealing with problems in real time and in highly emotive situations or situations that are quite urgent. So I think at the moment I haven't seen a specialist, like a specialist training course just for remote monitoring, but I definitely think it's something that we need. And it's something that we're looking in-house as well. But in terms of the competencies needed, excellent clinical assessment skills, and an ability to work autonomously as well.
Thank you ever so much, Becky. And I'll ask the rest of the panel, would anyone else like to comment on if they believe that there are new skills required, and if so, how they should be developed?
Can you hear me better? Is that better?
That's brilliant, Niall. There is no reverb. It's
yeah,
clear.
I've got a different network. Maybe that's what it was. So I think Sarah Zaidi in Essex has done a lot of work with NHS England on developing a training program for virtual wards, and I think there's a sort of in-house thing that we do for our new joiners, which there's a whole bunch of different competencies that we work our new nurses through. But I think there is specific training that is needed, definitely, because as I said, if anyone was able to hear me, it is a very different way of working.
It resonated much more with the advanced clinical practitioner nurse role that I'd be familiar with, or the nurse who works in ED who's got more assessment skills perhaps than your average nurse working on the ward, perhaps. And so those would traditionally have more training. So yeah, interesting to think about taking it forward. And as our resident physiotherapist, Jen, we've got the full MDT here today, guys, which is exactly how it should be, because this is an MDT activity. Have you got any thoughts?
I think what others have said, I do agree. I think advanced practice is a real key element, and having trajectories for people to get from, a band 3 HCA all the way up to advanced practice, I think is something we should be aspiring. And the remote assessment is becoming more and more part of what we're doing in the NHS, and COVID very much threw that at us, that we had to do it. So I think developing those skills, because you can't eyeball the patient, it is a very different level of skill. The other bit for me is really that focus on the personalisation and the shared decision making, because we're managing someone who is acutely unwell, more acutely unwell than perhaps we have done in the past in the community. We've always managed people who are acutely unwell, but we do need to have that collaboration between us as the healthcare professional and the person themselves in terms of the responsibilities around it, and for everyone in the team to understand that. I think we're not always so good at being, less hierarchical with our patients and telling them what to do. And I say that in the widest sense of healthcare professionals, not any in particular. So I think, it does become that that training element to empower people to take responsibility.
Wonderful. Thank you very, very much. And following on with the theme, there was some questions in relation to nurse to patient ratios, or I guess clinician, broadly speaking, about. So a question for you, Jen, how have you shaped that team, and how do you set the skill mix and the staffing levels for the team? Any tips and guidance, please?
iteratively is probably how I would describe it. We've built upwards. I think Niall has probably done something similar. So we have this lofty aspiration of the number of virtual ward beds that we should be providing, but we're very much going on a slow trajectory up to it in order to be able to refine what we're doing, understanding how much time a remote consultation takes if someone is escalating, and then being able to factor that into your workforce planning is really, really key. And we've had to learn as we've gone through that in terms of how many people escalate every day, and what does that look like, you know, how many times, how long does it take to get through to a clinician to perhaps escalate that care, all of that kind of stuff. But also considering your direct clinical care, so delivering actual acute care in the community, so delivering an IV antibiotic or delivering that management of a wound, or the physio seeing the patient and supporting their falls risk assessment, for example. All of those need to be captured in terms of activities that you might undertake depending on the pathway that you're having. We started off with a very, very basic set, which was that for the patients on our ward, we needed 2 people 12 hours a day doing the remote monitoring, and that every clinician who was on the ward could do in a 10-hour shift 5 to 6 visits, recognising we cover the whole of Bristol, North Somerset, South Gloucestershire. Is quite a large area, and so then we modelled our capacity based on that. That is extremely inelegant, and now I am trying to refine that now that we have more knowledge. So that's a non-answer. Apologies, I can't give anyone.
I think there were lots of really helpful tips in how to do this. And obviously in ward-based care, we've had the Safer Nursing Care tool for years, which is a really, it's basically what you described, but of course it's more evidence because we've been doing it for many, many more years.
Yes.
So perhaps an opportunity for people to work collaboratively to build big data sets to help us do that workforce modelling. But I was quite interested, Niall, in the chat, you answered in comments in terms of, you outlined the breadth, the levels of people you had in the team, quite a broad skill mix from very senior staff to more junior staff. Is there anything more you'd like to add?
I think the question about ratio is really to do with the acuity of the patients. And we've got to acknowledge that virtual hospital wards in this country cover an enormous range of different acuities, from, you know, patients with heart failure, quite sick, being stepped down from hospital, being visited at home, to patients who are being onboarded in the community in the sort of prevention of admission, where they may have a phone call alternate days. So identifying the staffing ratio really has to be modelled on the acuity, and that varies so much across the different models.
Thank you very, very much. I'm going to come to another question in the chat from David Duke. Thank you very much, David. And he says, as a patient, I sometimes find it difficult to express my symptoms. The data should reduce this problem with facts rather than feelings. Is this a general benefit? What do the panel think about that? Who would like to take that one?
I can take a first start. Yeah. I think one of the nice things about being on the remote monitoring is that it is an example. Say when you go to the GP and all of a sudden, you know, whatever symptom you wanted to explain to them has disappeared, or you leave the GP and you think, oh, I didn't mention such and such. And the nice thing about remote monitoring, even when it's long-term conditions, there's still that open line of communication. So I do think there's opportunities to for patients who might have symptoms where they're slightly more vague. There is an opportunity to pick up those things and just to have a bit more of an open conversation with the clinician, rather than it being strict rigid times at 7-10 minute consultations. I'll pass on that one.
Yeah, I mean, I think. Sorry, go on, Natasha. Apologies.
I'm mindful I've got loads of questions and I'm trying to hair through them. So if you've got a wonderful gem to add on top of that, let's have it. If not, shall I go to the next question?
I think what the remote technology does in terms of giving us... sorry.
Carry on.
No, I was just going to say that what it does potentially is, because people can articulate symptoms within the remote technology, it allows us to be able to target our conversation with that person to things that are important to them, which allows perhaps more time and space for clinicians to have that conversation. It's definitely feedback I've had from healthcare professionals. So I think although you may feel that you're giving us vague information. I think actually that vagueness sometimes is really, really helpful, because we can go in and lean into that and understand it with you a bit more in our consultation.
Wonderful. Thank you very, very much. And the other question that looked quite interesting, I'm just trying to scroll up, was from Hannah. Hannah, would you like to chip in with your question? Because I'm trying to find it at the moment slowly. Here we are. Is enough being done to develop the evidence base for virtual wards? I'm going to direct this to you, Niall. A recent review of evidence suggested that there's a good evidence base for hospital at home, but less for virtual wards. So I guess there's two parts to that question. Is there enough evidence base? And what's the difference between hospital at home and virtual wards? What are we talking about when we talk about virtual wards?
So I think the answer to that, so virtual ward, as I was going to say on one of my slides, is meant to be 2 weeks long. Hospital at home is a subgroup of virtual wards where patients are being visited at home frequently to have medical interventions at home, like IV antibiotics or fluids. I think the idea, I mean, it's not a term that's used in other countries, really, virtual wards. There's a lot of stuff about remote monitoring, and there's a lot of stuff about hospital at home. Virtual wards is a sort of new idea, but I think it is a very, very powerful, but it is sort of incumbent, I think, now on people running these virtual wards to develop the evidence base. So, you know, we go out visiting all the virtual wards in the East of England region, and one of the things I will say to people, you know, when they start showing me their data is, you know, publish this. And I think on the national team always go on about, please, you know, if you've got good data, share it. If you've got good data, publish it. Because people have said in the chat, you know, how about winning over the skeptics? And the way to do that is to you know, share excellent patient experiences and excellent data. So there is an evidence gap, but I mean, we've done stuff on our first 700 patients, heart failure and COPD, showing that people are in hospital about a third less, mortality rate 2.5%, and mean patient feedback 9 out of 10. You know, so that those are some headline data, and I think, you know, as people start to develop that sort of data, there'll be more and more data sets like that. So that's my answer.
Thank you very much, David. And I'm going to elaborate on this with another question that's come in from Stephen Boyle, which says, GPs have whole programs of training and competencies for remote care in video consultation. We should take some of that learning. So I guess if we elaborate on that question and say, so what's the learning we can take from others, be it other services, other professionals, or even internationally, to inform how we go about growing and developing this model of care? And how about Jen? You have a go at that one, if you don't mind.
Yeah, apologies. Can you just say it again? I just broke up just as you were talking.
No worries at all. So we've got a comment in the chat about learning from others who are already using sort of video consultation in different parts of practice, so in primary care. What's the learning we can take from other services, be it the 111 service, be it internationally, that could inform or have already informed how you're going about this?
Yeah, I mean, I would agree. I think it kind of goes back to my team of teams, doesn't it? You know, in terms of thinking about how you engage and learn from others in terms of who are already working in this space. I think, you know, 111, our out-of-hour GP services and many others, including GP colleagues, have been working in this space and building those skills. Again, it's about trying to find the time and capacity in everyone's diaries. I think now, you know, our workforce are very time poor to be able to share some of that, but I would agree that it is something that we need to do more of. Some of the universities are starting to do remote assessment type courses, and again, I think those are evolving over time to support, but also we do a lot of clinical supervision associated with it, so those that have more experience of it, perhaps sitting alongside those doing it and helping them to navigate some of the questions and the uncertainty. So thinking about how you do it in practice, I think, as well, because sometimes a course is helpful, but it's putting it in practice that is the key.
Brilliant. Thank you very much, Jen. And I can't believe it. We've actually come to the end of our time. It's 2 o'clock on the nose. And unfortunately, there's loads more questions in the chat, so perhaps we need webinar Mark 2 to get to some of those deep questions, but really great to see the curiosity and enthusiasm. And what I've really enjoyed is seeing in the chat that people are supporting each other and answering each other's questions. So hopefully some people will continue conversations outside this webinar. But I'd like to take the opportunity to thank 3 amazing speakers who are doing sterling work that has been fascinating to hear about, even with the technical challenges that we've had today. So thank you, everyone. The sun is shining. Have a wonderful afternoon. Take care. Bye-bye.